Again, welcome everybody to the UW Orthopedic Surgery and Sports Medicine Grand Rounds for June. We have a shoulder topic this month, and as we always do, we'll have a PGY for a fourth-year resident presenting alongside a faculty member. So this month will be Dr. Jason Khoo is our faculty mentor for Grand Rounds. He's an associate professor and the holder of the Frederick and Ann Matson Endowed Chair in Shoulder Surgery. So it's always a pleasure to have him giving his expertise, and partnered with him is Dr. Kevin Khoo, one of our fourth-year residents who is going into shoulder and elbow surgery for his fellowship. So it's a great combination here. And this morning, they're going to talk to us about the management of glenoid and humeral bone loss in primary and revision shoulder arthroplasty. Thank you, guys.
Thank you, Dr. G. Good morning, everyone. Shoulder arthroplasty is a well-established approach that has proven efficacy in treating pain and improving function for a host of pathologies. And as predicted in a previous study, the number of shoulder arthroplasties performed annually is rapidly increasing. And while shoulder arthroplasty frequently results in excellent outcomes, many pathologies can present with significant humeral and glenoid bone loss, complicating fixation of your implants. Furthermore, with the increase in number of primary shoulder arthroplasties performed, there's also been an increase in shoulder arthroplasty revision. And similarly, each type of revision can present with unique challenges resulting from glenoid and/or humeral bone loss, complicating revision surgery. In the setting of glenoid bone loss, fixation of the glenoid component can be compromised. In total shoulder arthroplasty, the gold standard for fixation is the use of a pegged component with cement. And in the setting of glenoid bone loss, stability of the component can be compromised, resulting in instability, accelerated wear, and eventual failure. In the setting of reverse shoulder arthroplasty, the glenoid base plate achieves fixation through a large central screw or post, frequently augmented by peripheral screws. And while fixation is more robust compared to the glenoid component in total shoulder arthroplasty, one can still have issues with glenoid component fixation in the setting of glenoid bone loss. This in turn can result in inappropriate implant positioning, compromise initial fixation and subsequent ingrowth, and ultimately result in component failure. Different shoulder pathologies can result in different glenoid bone loss patterns. And as a result, each patient presentation requires careful evaluation and preoperative planning prior to shoulder arthroplasty. Rotator cuff intact osteoarthritis represents one of the most common indications for shoulder arthroplasty, and when discussing this, it is helpful to use the Walsh classification to understand the different wear patterns observed. Type A represents osteoarthritis with a central wear pattern. Notably, the humeral head is centered in the glenoid without significant retroversion. And this allows a straightforward exposure. Typically, bone stock is preserved but in severe cases, significant bone loss can occur. In the initial classification, type B glenoids were characterized by posterior erosion of the glenoid, resulting in retroversion, posterior subluxation, and in type B2 glenoids, a biconcavity. The classification was subsequently expanded to include B3 glenoids, which is characterized by severe retroversion without biconcavity. An understanding of the pathologic mechanism is helpful in understanding how one must approach this alternative presentation. Normally, the humeral head is centered through concavity compression of the anterior and posterior rotator cuff. When concavity compression is unable to keep the humeral head centered, a posterior directed force on the humeral head leads to eccentric loading. Over time, posterior erosion progresses into the formation of a biconcavity and posterior subluxation. This combination of retroversion, bony erosion, and biconcavity in B2s present challenges with exposure and obtaining stable implant fixation. In this example, the biconcavity persists after improper reaming in the top image, and this prevents complete seating of the poly in the bottom image, resulting in an unsupported glenoid component that is prone to loosening and early failure. In the setting of an incompetent superior rotator cuff, The proximal pull of the deltoid results in superior subluxation of the humeral head and superior erosion. Acetabularization results from the humeral head articulating with the coracoacromial arch. Cuff tear arthropathy can be classified according to the Favard classification, depicting different magnitudes of superior erosion. As depicted in this postoperative radiograph, we prefer to have an inferior tilt of the base plate for biomechanical stability. One can imagine superior fixation would be limited in the setting of significant superior erosion. And in this way, superior erosion can complicate proper positioning of the base plate and achieving stable fixation. Inflammatory arthropathy is characterized by central erosive pattern, and in some cases with severe medialization of the humeral head. In addition to sometimes significant glenoid bone loss, bone quality is compromised in the setting of chronic inflammation, complicating any attempts at glenoid component fixation. In Charcot arthropathy, patients may present with profound glenoid and/or humeral bone loss secondary to the absence of protective effects of the nerve supply. Post-traumatic arthritis can develop from prior fractures and/or dislocations of the humeral head. In some cases, particularly in the elderly, these are treated with arthroplasty as opposed to ORIF. In cases of recurrent and/or chronically dislocated humeral heads, one can see significant glenoid bone loss or fracture that could compromise implant stability. Transitioning to the revision setting, it is important to recognize that each type of shoulder arthroplasty can present with different patterns of glenoid bone loss. While not a common issue, some patients after hemiarthroplasty can develop significant glenoid erosion from their humeral component. Similar to the mechanism of cuff tear arthropathy, patients can also develop an insufficient superior cuff, resulting in superior wear and presenting similar challenges due to the superior erosion. In the setting of prior total shoulder arthroplasty, there are multiple mechanisms by which glenoid bone loss can develop, one of which is the rocking horse phenomenon. The underlying mechanism is similar to the development of posterior erosion seen in type B glenoids. With the loss of concavity compression, there is a resultant anterior-posterior instability of the humeral head on the glenoid. And this results in eccentric loading of the glenoid poly. Cyclic eccentric loading subsequently results in unequal wear and toggling of the component, akin to the rocking horse figure shown. Ultimately, this results in accelerated wear of the glenoid component, loosening, and failure, and all of these result in attritional erosion of the glenoid. Accelerated wear of the poly can also result in osteolysis, further contributing to the loosening of the glenoid component and ultimately contributing to glenoid bone loss. Like in hemiarthroplasty, patients can develop an insufficient superior cuff after total shoulder arthroplasty, resulting in superior loading of the glenoid component. And similar to the rocking horse phenomenon, this eccentric loading will result in accelerated poly wear, loosening, and failure. Glenoid bone loss can also result intraoperatively at the time of component removal. In the setting of a well-fixed, cemented, and/or keeled component, one can have significant bone loss during component removal, like that seen in this intraoperative photo. The Antuna classification was developed to characterize different patterns of bone loss, and as one might anticipate, those with more severe bone loss and uncontained defects represent more challenging cases to achieve component fixation. Due to the rigid fixation achieved in reverse shoulder arthroplasty base plates, base plate failure and resultant glenoid bone loss is less common. And while not common, catastrophic failure can be seen in the setting of trauma. One might also see bone loss in the setting of scapular notching, resulting from attritional impingement of the humerus on the inferior glenoid, resulting in glenoid erosion and component breakage. In either scenario, glenoid bone loss can compromise fixation achieved at the time of revision arthroplasty. Turning our attention to the humerus, the primary goal when managing the humeral component is achieving adequate initial fixation for eventual integration. This can be achieved through press fitting a stem, bone grafting a smooth stem, and cementation. In the primary setting, humeral bone stock is typically adequate for fixation. This is sometimes not the case in the setting of prior injury or shoulder surgery.
I just hate that it says Eli Bunzel is left.
Thank you, Dr. Bunzel. Proximal humeral nonunion can present with significant deformity that can complicate fixation of the humeral component. Similarly, after prior proximal humerus ORIF, one can see deformity and bone resorption, complicating humeral component fixation. And as discussed previously, fracture dislocation can also result in humeral bone loss. In the setting of revision, multiple mechanisms can contribute to humeral bone loss. After total shoulder arthroplasty, osteolysis can develop around the humeral component, which in turn can result in loosening. In the setting of a poorly fixed component, toggling of the component can lead to attritional bone loss. And similar to the glenoid side, at the time of component removal, humeral bone loss can result during the removal process. In this image, we can see extensive bone loss after humeral component removal around an antibiotic spacer. The Farrell's classification is useful to characterize patterns of humeral bone loss as well as guide surgical treatment. Type 1 defects indicate a likely rotator cuff compromise, and type 2 defects are more significant but do not include the deltoid insertion. In contrast, type 3 defects indicate the deltoid insertion is potentially compromised and may require soft tissue reconstruction. And while there are many potential problems that can arise from glenoid and/or humeral bone loss in shoulder arthroplasty, there are many techniques and approaches for addressing these problems. And with that, I'll hand it off to Dr. Khoo to show us his approach to tackling these various challenges.
All right, thanks, Kevin. All right, that was a great overview of the primary reasons why we might see glenoid and humeral bone loss and shoulder arthroplasty. And so for the next 30 minutes, I'll talk about management and the challenges that we face in cases of bone loss. So these are my disclosures. I do have a relevant disclosure with Enovis, but I'll discuss a lot of different implant designs throughout the talk. So Kevin went over some of the main etiologies for glenoid bone loss, and when we talk about management, we generally consider three main types of arthroplasty, which would be anatomic total shoulder, reverse total shoulder, and hemiarthroplasty. And by the way, we won't be talking about periprosthetic infection at all today, but in the revision setting, it's important to consider both the workup and the management. But today we won't be talking a lot about antibiotic spacers and things related to that. So for cuff intact arthritis, hemiarthroplasty, particularly the Riemann run, is an option for patients that place high demands on their shoulders, but that's a whole nother grand rounds. We're going to be focusing mainly on anatomic and reverse arthroplasty, mostly about the challenges in terms of fixation with those two types. Outside of cuff intact arthritis, we typically are looking at reverse arthroplasty for the option for the other etiologies, mainly because these are associated with either cuff deficiency or because the glenoid bone stock is deficient. So it would be impossible to see it in anatomic polyglenoid. But let's focus on cuff intact arthritis first. And as Kevin discussed, it's really these forms of posterior eccentric arthritis with the B2 and the B3 glenoids where the humeral head has caused posterior bone loss that we get concerned about. And that's because, as Kevin showed with the biconcavity and posterior decentering of the humeral head, there's concerns with glenoid component failure. So in the case of this Walsh A1 glenoid, an anatomic total shoulder with a polyglenoid is a pretty straightforward surgery. We have a nice monoconcave surface to seat the glenoid on, and it's not as much of a challenge to get complete seating. So this is generally considered a fairly straightforward surgery. But then when you look at a Walsh B2 glenoid where we have a biconcavity, there's two concerns. One is the biconcavity that won't support a polyglenoid. And then we also have posterior decentering where the humeral head is sitting posterior to the center of the glenoid face. So let's take a closer look at the options here when we have some bone loss posteriorly, which creates a biconcavity. If we try to ream the glenoid, we don't get complete seating. We'll run into issues with rocking horse loosening, as Kevin mentioned, and that's clearly not good to have an unsupported part of the polyglenoid that could lead to toggling and early loosening. So we can take a few different approaches. The first is that we could ream the glenoid to a monoconcave surface and correct or restore the native version. But as we correct version, we medialize as we ream, and we lose some bone stock, and the size of the glenoid component may be smaller as a result. So one other consideration is doing non-corrective reaming, and in this approach, we ream the glenoid with just to get a single concavity. We don't really do anything to try to correct the version. The goal with this approach is just to make sure the glenoid is completely seated on bone, and we ensure the humeral head stays centered through soft tissue balancing. And another option is to use an augmented glenoid where the posterior side of the glenoid component is thicker, and so it can correct retroversion without removing too much additional bone. Uh, the use of these augments has really increased these days, and most manufacturers have some type of augment option. And there's a couple different designs with half wedge options where the thicker portion starts at the center, and then there's full wedge options where the complete backside is angled. And so again, both these types can be used to treat biconcavity and correct version. And one proposed advantage to this is that it restores it corrects version and it restores native joint line. But there are some concerns with augments, and one of them is that when you have a thicker poly in the back, there's a larger lift-off moment arm. And so if you have any eccentric loading on the posterior glenoid component, the concern is that you could see some potential acceleration of glenoid loosening. But we don't really have any great long-term data on augments or any great data comparing augments versus standard glenoid components yet. So I think Dr. Schiffman, Dr. Matson, and I all approach this in a similar way with posterior bone loss. And I think we approach this primarily with non-corrective or minimally corrective reaming with the standard polyglenoid. And with this approach, our goal is to minimize the amount of bone that needs to be reamed. We're just really getting rid of that biconcavity and then seating the component. And we have some good long-term data showing that regardless of the morphology of the glenoid, whether it's A1, A2 and centered, or whether it's B2 and B3, you have posterior glenoid bone loss, that we can get good functional results long-term. But there is some concern that implanting a component in retroversion can lead to peg osteolysis. And this is one of the most commonly cited study at a Cleveland clinic where Kevin is heading to fellowship, showing that osteolysis with component placement in more than 15 degrees of retroversion had an odds ratio of 5.2. And so a lot of people are concerned that if you implant the component in retroversion, that it may lead to early loosening. One of our recent fellows, Mihir Sheth, looked at concentric and eccentric osteoarthritis and found that in a multivariate analysis that maybe it's not the post-op component version that's as important as other things like seating of the glenoid component. And there was a similar study out of WashU in St. Louis that also found that glenoid seating and post-op humeral head decentering were associated with failure of the glenoid component. And so some of this data suggests that while implanting the component in retroversion may contribute somewhat, there are other factors during surgery which might play a more important role in really getting the component seated might be more important. So here's an example of a 55-year-old severe posterior glenoid bone loss and retroversion B3 glenoid. Retroversion is measured at 40 degrees, which is quite a lot. And we approach this with non-corrective reaming in a standard glenoid component. And you can see that we implanted the component in retroversion. We didn't try to correct version at all. And some of the pegs of the glenoid component may perforate the anterior glenoid vault because of this, but peg perforation may not matter that much. In this case, there were two main goals. One was to get complete seating of the glenoid component, and the other was to ensure that the humeral head was centered on the glenoid throughout the range of motion. And that's done through soft tissue balancing, which is a whole different topic in itself. So I've talked a lot about different ways to approach posterior bone loss and cuff intact arthritis with anatomic arthroplasty, but the reality is that the trend these days is that many surgeons are doing reverse arthroplasty for this. And there's a lot of different reasons for that. The primary one is that in these cases of posterior bone loss, the surgeons are often worried about loosening of an anatomic poly. And with reverse arthroplasty, we can use screws and metal in the glenoid component, and this allows for better fixation. and bone ingrowth into the component. And there are some studies showing that the functional outcomes with these two types of arthroplasty can be similar. And this is likely one of the reasons why we see a big rise in the proportion of reverse arthroplasty. This is data from the Australian registry showing that 80 to 90% of primary arthroplasties are undergoing reverse arthroplasty, less than 10% are anatomic. And I think this trend is heading that way in the United States as well. So we touched on the approaches to cuff intact arthritis with anatomic and reverse arthroplasty. And for the most part, these other etiologies of glenoid bone loss typically are approached with reverse arthroplasty, again, because of cuff deficiency or inability to get good fixation because of bone loss on the glenoid side. And pretty much every design of and manufacturer of reverse arthroplasty has some type of augmented system that can make up for bone loss, and we'll show some examples of that. But before we get into case examples, I'll review some of the types of glenoid bone defects that we're approaching. And these can typically be divided into centric defects where there's central bone loss, and then peripheral bone where the peripheral bone is still intact, and then you have eccentric bone loss where there's one side missing, and there's typically a little harder. It's a little harder to address this because there's the uncontained nature of the defect. So when you look at centric defects, these typically aren't as hard to address because there's often good peripheral cortical bone to support a base plate. And so our options are impaction grafting, where you can see here that we removed a total shoulder and it's left a big cavitary defect, and we just we impaction graft with bone chips, and we stuff the hole with cancellous bone, use a tamp to compact the bone as densely as possible. Then we can use structural graft, which in the shoulder, most people typically either use femoral height allograft or iliac crest bone graft, or we can just use metal. And most designs of base plates have some sort of boss, and you can see that there's metal coming from the base plate, and that element can fill part of the defect and potentially encourage bone ingrowth into that surface as well. For eccentric defects, this is where things get a little bit harder, because if we don't have good cortical bone on one side of the defect, then there might be issues with toggling of the base plate and base plate failure. And so the technical aspects are generally a little bit more difficult. So in general, you can approach these eccentric defects with structural graft. You can use metal augments on the base plate itself. And then I'll briefly touch on custom components. My personal preference is using structural graft with a standard base plate. But I would say the current trend, most people are using augmented base plate, and including my partner, Dr. Schiffman, and we'll show some cases of his that use augmented base plates. And I think this is a good option, and we'll go through the pros and cons of each. So here are the cases that we'll consider, and we'll start with the more straightforward cases. One is cuff intact arthritis with a B2 glenoid, severe posterior humeral head decentering. The second case here, cuff tear arthropathy, superior glenoid erosion. And then we'll get into some more complex cases. And so you may want to think about how you would address the bone in these cases. So the third one here is cuff intact this is a anterior glenoid bone loss with a chronic dislocation. Then we have a severe posterior superior erosion after a hemiarthroplasty. And then we have erosive arthritis with severe medialization. So these are three of my cases. I addressed them all with standard base plate, with or without bone grafting. I'll go through my thought process on this. But let's go back to this first case here. So this is a cuff intact arthritis with posterior biconcavity. And we had discussed different types of ways of addressing this, including non-corrective reaming augments with anatomic arthroplasty. But a very common approach these days is to use a posteriorly augmented reverse base plate to get fixation with use of a posterior augment to make up for that bone loss back there. And so this was done, and you can see this is a case of Dr. Schiffman's. He did a nice job at using the posterior augment to make up for the posterior bone loss, and the patient has done really well with this. The same concept can be used to use these augments in cuff tear arthropathy, and as Kevin talked about, because of in cuff tear arthropathy, because of cuff insufficiency superiorly and posteriorly, there's often superior glenoid bone loss, and that can be pretty common in these cases. And it can be a challenge to get good seating and fixation of the base plate. Oftentimes we're trying to get the base plate to be somewhat closer to perpendicular to this blue line right here. But you can see that the face of the glenoid faces upwards, and if we implant the reverse base plate at that angle, we're looking at potentially getting scapular notching or potential screw cutout and base plate failure. So again, this is a case of Dr. Schiffman's. He used the augment superiorly to better correct this angle without having to ream any of the bone inferiorly substantially. So those were two good examples of using an augment to correct retroversion or superior inclination to improve the alignment of a reverse arthroplasty. And I'll show you a couple cases of using a standard base plate with bone grafting as another option. So this is the third example, third case, 70-year-old osteoporotic lady with RA that has a chronic anterior dislocation where the anterior glenoid bone has been eroded. And so again, the options here are using an augment anteriorly, or we could use a standard base plate with bone graft. And so that was my my plan here. So I don't typically use a lot of preoperative planning, but it can oftentimes be helpful for surgeons. And in some ways, some of the different pre-op planning software, you can plan the placement of the base plate, you can measure the size of the graft that you need. And so this is how we approach the case intraoperatively. So you can see here on the CT scan, the humeral head has caused a defect into the anterior glenoid. And what we're trying to do here is we're trying to recreate bone in this defect. And it really was created by the humeral head itself. So it makes sense that this concavity here is caused by this humeral head, and we can just take the humeral head. So intraoperatively, here you can see that there's very little native bone here. And this white area right here is actually bone wax, and we use that to mold the glenoid vault to where we think it should be. And you can see that once we take that bone wax out, we can then take a wedge of the humeral head to match that graft, and that should fit to where we think the glenoid vault will be. So then we get provisional fixation with K-wires. We put our central screw, tap in. I use this monoblock central screw device, and then we get compression with that central screw base plate, and then we put some peripheral screws in. And you can see that after we're done, we get good compression of this bone graft right here. And this patient has done well with this. And this can be done with a B3 glenoid on the other side. So you can see this is a severe B3 glenoid where there's severe posterior erosion. Again, if you kind of think about where the glenoid vault originally was, natively, you can see that the humeral head has eroded that away, and we can just, because the humeral head took the glenoid bone away, we can just take back the humeral head during surgery. And you can see that we placed a wedge of the humeral head back here, and we can implant a standard base plate. So here's another challenging case is a 48-year-old female with severe posterior superior wear from a hemi done 20 years ago. And we can't use humeral head autograft in this case, so our options are iliac crest, or we can use femoral head allograft. And again, you could consider an augmented base plate in this scenario, but I'll talk later about some reasons why an augment in these cases might not be the right choice. You can see that she has a massive amount of posterior superior bone loss, and similar to the last case, we plan out our base plate placement here. We take a large piece of iliac crest and fashion it to fit this defect, and we can pin it with a K-wire and then proceed with base plate placement in the rest of the case. And you can see that we can get great fixation of the graft to the native bone with compression through the base plate, and she has done very well with this. This is another more challenging case. We have a 66-year-old female who had 2 rotator cuff surgeries, and for some reason was starting to see both humeral head and the glenoid start to disintegrate. And a big workup was done to rule out Charcot, a syrinx, rule out infection, some neoplastic process, but in the end, nothing was found. And she was left with this glenoid that had eroded a couple centimeters medially, and that you can see that there's a big challenge here where there's no bone anywhere to support a graft or an augment. And so in these cases, I have used just a standard central screw base plate and a technique called the alternative center line. And this is probably the biggest game changer for me in terms of both, primary and revision arthroplasty with severe bone loss. And so this is a method of getting glenoid fixation when there's massive amount of bone loss. And this can be done whether there's posterior bone loss, anterior bone loss, medial bone loss, or central. And so normally when we implant a base plate, we're doing it perpendicular to the face of the glenoid, and our central base plate element often perforates out the anterior vault. But the concept with the alternative center line is that you direct the central screw of the base plate into a column of bone here. Uh, it's the central part of the glenoid vault here. It's where the scapular spine and the base of the coracoid meet. And this allows the central screw to capture some really hard, good bone, and allows you to get great compression with your central screw. And again, I'm not a huge user of pre-op planning, but this is one case where it can be helpful to imagine the starting point and trajectory of your drill. And typically we start a little bit more anterior than usual, and you really have to antivert and inferiorly tilt your drill. And your goal here is to really get that drill and that central screw into this hard column pillar of bone. And so in this case of severe immobilization, we can still get great fixation with a 6.5 central screw, allows for a very good compression. And I think in a lot of these patients, we probably would have thrown up our hands and treated this non-op or just put in a hemi in, but this allows for patients to get good function and good pain relief. And you can see the x-rays don't, they look a little odd because you're antiverting the glenoid base plate and you're inferiorly tilting it a lot. So it doesn't look like your typical reverse arthroplasty, and the x-rays can look odd, but these you can get very good fixation here. And so here's another lady that had a failed total shoulder with a loose glenoid that left a big cavitary defect in the glenoid. And so the only way that we could get fixation was to antivert and inferiorly tilt the base plate in the glenosphere. In this case, we use femoral head allograft as well behind it to support it. But you can see that these screws are going up into this nice hard pillar of bone. The results in the literature are pretty good, and the original report of this alternative center line was in 2010. And since then, there's been a number of different surgeons that have reported case series, and the rate of base plate failure is pretty low. So I've just talked a bunch about using a standard base plate and some bone grafting, but we have augments. And so which is better? Do we use bone or do we use augments? And I would say that the vast majority of surgeons these days are using augments, and that's for a number of different reasons. Mainly, there's more precise instrumentation. So there's specialized reamers. You put a guide pin in here, and there's reamers that can make sure that your augment is in the perfect spot, and you can be really precise with it. And because the augment is part of the base plate, there's no need to fashion a bone graft. And then unlike bone, which can potentially resorb, you don't have to worry about that with an augment and it being metal. So you might wonder why you would ever consider using a bone graft in a standard base plate. And I'll cover a couple of reasons. And one is that most augments require a boss. And so in severe bone loss cases, you can imagine that when you're missing a lot of bone here, it might be impossible to fit a boss into a small amount of bone, and you might end up fracturing the glenoid as a result. Second reason is that when you use an augment and a central screw device, it has to come in two pieces. And you have to be able to align the augment in the direction that you want it to sit on the glenoid, and then you have a separate central element or screw that you screw into the boss. And I think biomechanically, the stability of the overall construct is not as good. And our goals when getting base plate fixation are really to minimize micromotion. And there's generally this threshold of 150 microns that you can that you want to stay beneath. And so this is a study looking at monoblock or one-piece base plate versus a two-piece design, and with different amounts of torque of the base plate. But you can see here that in a two-piece design, there's a little bit more risk of getting increased micromotion with repetitive cycling. And so that puts the construct at risk for failure. And so the third reason is that there's just that extra interface in the two-piece design. There's another juncture for failure. And so really the base plate needs to be fully supported on the backside, because if it's not, you can get some base plate trying to toggle, and that force through the glenosphere to the base plate, that gets transferred to the central element, and that juncture, rather than in a one piece design, it directly goes down to the screw into good bone in a one piece design. So there are studies out there showing that in a one piece design, you really only need about 50% seating of the base plate. And so that allows more flexibility in terms of how you manage bone loss. So ultimately, while most surgeons use augments and some others might use bone graft, there's pros and cons to each. You just have to understand how to best utilize the procedure that you pick, and either one can work well with good execution of the surgical principles. And so um, I think there are a lot of different different companies that offer custom components these days. And so what you can do here is get a CT scan and send it off to the company, and they can make these custom devices. This is an example of one custom case where a patient had a severe glenoid fracture that was intended to be fixed, and everything fell apart, got a non-union of the glenoid, and hemiarthroplasty was done. And you can see there was severe medialization. And in this case, you use patient-specific instrumentation. In this case, we actually used an acetabular reamer to get um, a sphere of bone here that we could then implant a custom device into that area. So there are some drawbacks to these custom components, mainly that if you don't have a quick turnaround time from the time you get the CT to when you do your surgery, there can be changes in the bony structure that can occur. And you can imagine with the scapula, we're dealing with putting screws in locations that are sometimes very thin and narrow. And if anything is off by a couple of millimeters or a couple of degrees, the whole construct might not work as you intend. And so, and you can imagine that with these custom components, there's large moment arms, and so these can be sometimes difficult cases. The last thing I'll say on the topic of glenoid bone loss is that while we talk about reverse arthroplasty as a procedure of choice, sometimes it's either not possible or not desirable to put in a reverse arthroplasty in a patient. And so a hemiarthroplasty can be a reasonable option. And so Kevin wrote this paper recently looking at 29 patients that had failed total shoulder that were converted to hemiarthroplasty. And overall, you can see that the pain scores go down and function improves. And one of our previous fellows, Ben Sharare, looked at this topic and did a systematic review, found that in the literature, conversion to hemi or conversion to reverse for a failed total shoulder really had no difference in reoperation rates. And there's a pretty high reoperation rate of almost 20%. But overall satisfaction was higher in the reverse arthroplasty. I think that's likely because the pain relief might be a little bit more predictable with the reverse construct. So moving on to humeral bone loss, Kevin went over some of the reasons for humeral bone loss. And again, a lot of them are mainly due to either something related to a previous proximal humerus fracture or surgery, and the other is revision arthroplasty. And a common theme again is that proximal humerus fractures, whether you treat them with surgery or without surgery, they can be very challenging to get a good result. Even when you go to arthroplasty, because if you're missing proximal bone, that proximal bone is so important in reverse arthroplasty in specific, because if you're missing that, you essentially have a circular stem and a circular canal, and there's so much force on that reverse arthroplasty that you can start to get loosening. So when we look at options for humeral bone loss, other than implanting a standard component and cementing it, the options come down to just like the glenoid, bone versus metal. With bone, you can consider a proximal humeral APC, and the other option would be metal, which is a megaprosthesis. And so with proximal humeral APC, you use a proximal humeral allograft that's fixed to the native bone to support the proximal portion of the implant. And so there are different ways to go about this surgery, and you can fix it with plates, you can fix it with cables. There are different ways to consider joining the graft to the native bone. So here's an example, 65-year-old who had failed proximal humerus RF and went on to hemiarthroplasty. And you can see that hemiarthroplasty failed, and you can see the stem is loose. And there was some concern for infection, so he underwent a two-stage procedure, an antibiotic spacer first, and then a reverse with a proximal graft. And you can see that after the antibiotic spacer, he still didn't have very much function. So we ended up doing a proximal humerus APC with reverse. And one of the options for APCs is to do a transverse cut. And we really want to make sure that we maximize the amount of compression, and we want a perfect match between the graft and the native bone. So I've used the specialized planer that has an extension that goes down into the canal, and you can plane it both ways so that once you're done reaming both sides, you can have perfect alignment so that when you put the stem down into the canal, you can then plate it, and it can usually fit perfectly. So we put a plate to provide both compression and stability of the graft to the native bone. I typically still cement these stems fully into the graft. And so here's another example. And this is pretty typical. Lady had a failed ORIF, then a hemi. That didn't work out. She had a reverse, but really didn't have any proximal bone. And so within a couple of years of having the reverse, she had implant loosening, and you can see that she's about to fracture out the lateral cortex. So we did a transverse cut, plane both sides down, and compressed the graft to native bone. There's also the option of using a step cut, which can provide a little bit more surface area. And you can see that in this case, I borrowed this from Eric Ricchetti at Cleveland Clinic. You can see that with a step cut, you can use cables to compress the step cut side to side, and you can see you can get a nice result with that as well. So here's another case. You can see that this was a reverse arthroplasty done for cuff tear arthropathy maybe 15 years ago, I think. And you can see that there's a lot of osteolysis. There's a cement fracture of the mantle. And in most cases, it's important to remember that the key to maintaining function for these patients when you revise them is to ensure that the deltoid insertion isn't compromised. And you can see in this case, the bone quality of the proximal humerus is not very good. The cortices are all blown out. But instead of taking all that bone out and doing a transverse cut and potentially compromising the deltoid insertion, we can actually remove the stem and the cement and consider taking the graft and intussuscepting it into the remaining bone. And so this is an example of one where this is actually a trephine from a revision hip arthroplasty set, and we core out the native canal first with a certain diameter, and then we use a corresponding size trephine, which can allow us to get a line-to-line fit of the graft within the native canal. And so you can see that despite the native bone being blown out, you can see the native bone goes up about to right here. We can get the distal allograft to fit within the canal, and that provides good biomechanical stability for the entire construct. I still plate and put skiving screws around the stem as well. So the survivorship of proximal humeral APCs is reported to be about 90 to 95% at 5 years, a bit lower longer term. But the complication rate from this procedure can be pretty high, and it's reported as high as 46%, especially instability can be a problem. And the one thing you'll notice in that many of the technical reports, these grafts can come with or without soft tissue attachments with the rotator cuff. And it's better to use APC with soft tissue attachments because you can tie it into the native soft tissue that helps with stability of the implant. And but the issue is that grafts with soft tissue attachments, at least in my experience, they're very difficult to get. And we don't have a freezer at our institution. We can't, if we find one, we can't store it, and it's very hard to just find one. So I haven't had the ability to get that, and so I have had my fair share of instability after this procedure. And one thing that we can do to try to decrease instability or help with stability is glenohumeral cerclage. So we tie some fiber tape behind or into the base plate, and then we cerclage it around the humerus to help provide stability to the construct while everything is healing up. And the last thing I'll show is the use of a megaprosthesis. You can see that this is an example of a short stem reverse where the patient fell and sustained a periprosthetic fracture. And instead of using proximal humeral allograft, a megaprosthesis was inserted. And this is the patient's X-ray at 3 years. And just like the glenoid side, how do you choose between bone and metal? And it's not always clear. In general, the proximal humeral APC cases are technically difficult. But if you can get them to heal, you might not have to worry as much about implant loosening. And the mega prostheses are going to be quicker surgeries that are much easier to do. But even with these newer designs with flanges, it's not clear that the loosening risk is mitigated enough to get good long-term results. So we're going to have to follow these out longer. So in summary, posterior glenoid bone loss and cuff intact arthritis, we can treat that in many different ways. Non-corrective reaming with a standard component, we could use an augment or reverse arthroplasty. For both glenoid and humeral bone loss, the real kind of controversy is whether you use bone or metal. With glenoid bone loss, I'm a fan of using a standard base plate with structural bone graft, but definitely the trend is using augmented base plate. I'm a big fan of the alternative center line to really get good fixation and compression of the base plate. And then for humeral bone loss, we're looking at either using a proximal humeral APC or megaprosthesis. The biggest thing here is that no matter what you choose, you just have to know what the pitfalls are and just learn the technique and follow these out long term. Thank you.
Nice job, Dr. Shu and Dr. Khoo. Great, very comprehensive review of that topic. Do we have any questions from anybody in the audience? Please feel free to unmute and ask, and you can also text into the chat if there's a question that you want to send to us that way. I can start us off, Jason. I guess, I have to assume that the mega prosthesis is not a cheap thing to get your hands on. I guess allografts are not inexpensive either. So has there been any, with hospitals trying to cut costs, all of us trying to bring down the cost of healthcare, have you any insight into, the costs of these things? Is there any benefit to one versus the other on a value perspective?
That's a good question. I haven't looked into that. I know that the mega prostheses for sure are very expensive. Um, Proximal humeral allograft is expensive as well. I don't think it's going to be as expensive, but then you also have to balance in the surgical time because doing a proximal humeral APC, getting that to fit, plating it, that's at least, couple hour procedure, whereas a meg prosthesis, you're cementing in a stem and then it's a much quicker procedure. So that would be an interesting question to look at.
Nick has a question here. The alternative center line technique seems great. Any techniques to address the amount of lengthening you end up creating in what are inherently tight shoulders due to bone loss? And is there a known higher rate of nerve injury or neuropraxia?
Yeah, that's a good question. I think typically these are very medialized glenoids, and then when we're putting the base plate down and reaming it down, we're fairly medial. And then uh, depending on the implant system that you use, you can get different amounts of fill with either the size of the glenosphere or the amount of lateralization. And so there are different options in terms of how much, the size and the I guess lateralization of your glenosphere implant so that you can try to avoid over lateralizing and over distalizing.
Is there data about nerve injury with increase? I mean, that seems like would be a consideration, but is there a known amount that you're able to lateralize before you start to worry? I mean, I guess it's not something you can really measure. You kind of do it on feel.
Yeah, there's some studies out there looking at a few centimeters of distalization as a risk for neuropraxia, but lateralization, I'm not aware of any studies that have really looked at nerve injury related to that.
Yeah.
Great job, Jason and Kevin. This is Corey. I'm curious, with this boom in technology and these new types of implants, where do you think we're going to be going next? So 10 years from now, what do you think people are going to be putting in? And is it something that you would consider? I know we're very data driven, but what do you think is next that would help make these revision surgeries easier in your hands?
That's a great question. So Kevin, you want to try that?
I think one of the things that will push towards augments as opposed to the graft is just how accessible it is, like with the specialized reamers and cutting guides, that I think it's a faster surgery that people that aren't familiar with or comfortable with um, rebuilding bone through graft will turn to. And so I think there'll be a lot more revisions for augments in the future.
Yeah, I agree. I think overall the technology and the implant systems that are coming out are getting better and better. Just like reverse arthroplasty, 20, 30 years ago, it was seen as very radical, but it has really changed the way that we look at things. I think in terms of revision arthroplasty, we're so used to using bone to account for uh, bone loss, and I think finding different ways of getting good long-term fixation of metal is probably going to be the way forward. I don't think we're there yet, though.
Jordan had
Yeah,
his hand
I
up.
did.
Yeah.
Jason, quick question. You don't use any of the imaging software for planning. I haven't used it myself, but it seems every young surgeon coming out is using it. What's your rationale for not using it? And do you think there's any real uh, disadvantage not using it versus an advantage to using it? Because it does allow you to, get that base plate in the right position from what I've seen.
Yeah, I think so I don't think it's a bad thing to use pre-op planning for young surgeons or senior surgeons to look at where you're going to put your implants, and I don't think it's a bad thing. I think with experience with good x-rays that we're able to get here, I haven't found a difference in using pre-op planning for straightforward cases. I do think there's a lot of um, uh, advantage to using it in more complex cases of bone loss, and it can really help you to determine where you're gonna, drill. But I think there's a lot of things that you can do by looking at an X-ray and looking intraoperatively at what you're doing to make sure that you get the result that you want. So again, I'm not against pre-op planning. I think it's a great thing to learn, and we still get CT scans and have our fellows look at pre-op planning. But I typically just have been accustomed to just being able to use intraoperative kind of just feel and guidance.
Is pre-op planning available on a generic basis, or are they all tied to a manufacturer in the shoulder world?
I think they're all typically, you have to have some manufacturer with software. You can pretty much take any CT scan these days and put it into any manufacturer's software system, and it's pretty nice. It makes it easy to look at the anatomy and plan out where you're going to put the implants.
Yeah.
I think one of the big challenges right now is that, especially with reverse arthroplasty, I don't think anyone can agree on where we need to put the implants. So you can plan it how you want it, and you can try to execute that, but in the end, I don't think there's consensus on where exactly we need to be.
Yeah, really interesting stuff. A very nice presentation from both of you. Thank you guys so much. I don't see any other questions, so I think we'll wrap for this month. Thank you everybody for joining us for Grand Rounds. We'll plan to see you all next month.